I like to see my face up once in a while, so apologies. So I'm skipping some of the usual introductory slides about dry eye, because when you talk about drug, first you talk about dry eye and its pathophysiology, etc. We'll skip all that. Important thing is that we are now well aware, courtesy Restasis, which came in as the first immunomodulator drug quite a few years ago. So we know that the elegant people who started marketing Restasis told us about the inflammatory component of dry eye, which is very important for us to tackle, and that there is a vicious cycle which occurs, and breaking that immune cycle is an important step in the treatment of dry eye. So there is a normal ocular immune response, and which is called a regulated response or an adaptive response. And the what occurs in dry eye is a dysregulated response, where the vicious cycle goes on and on. So topical cyclosporin was first developed to target cytokine release. So what happens is, whenever there is an inflammation, the white blood cells come to the surface, where the white blood cells then release cytokines. These inflammatory cytokines worsen the cycle, the vicious cycle. So one of the things that topical Restasis did was to target the cytokine release, and up to now that was the mainstay of controlling inflammation in dry eye disease. However, cyclosporin takes some time to act, in 90 days if you look at the original papers, and some side effects, and there are a lot of people who discontinue this because of the side effects in this. And a survey published in USA way back in 2009 said 94% of ophthalmologists were unhappy and wanted a better drug for this. So let us now look a little deeper into the pathophysiology of dry eye. It's basically T cell mediated, and T cells play a great role. So there is a 6-step pathway of inflammation. There is antigen processing by the antigen processing cells, or APCs, on the surface. The priming of T cells in the lymphoid compartments. Outside the eye, there are lymphoid compartments. They get primed because of the antigen presenting cells. Those T cells now find their way through the overpacked trains like the blood vessels, and come through the blood vessels to the ocular surface. The conjunctival stroma is waiting for them and says, "Oh, I need you people, come here." It recruits those T cells. Those T cells get activated. The T cells get retained, and then they release cytokines, and therefore the pathway occurs. So for this, I'm going to give you some abbreviations which I will amplify for you. LFA1, ICAM1 pathway is crucial for T cell recruitment and adhesion to amplify inflammation. I'll explain what I mean. So if you can block the interaction between LFA1 and ICAM1 interaction, it may prevent further ocular surface damage, because you will prevent the T cells from coming there. Now, what do I mean by LFA1 and ICAM1? So ICAM1, if you imagine this clown, that's the inflamed epithelial cell. So the inflamed epithelial cell, you see his cap, that there is an ICAM1 ligand. Ligand means a protein strip, protein molecule that attracts T cells. So that funny cap of his is attracting T cells. That's the ICAM1. And LFA1, what is LFA1? LFA1 is an integrin or a protein which is on the surface of the leukocyte, which is attracted to the ICAM1. So the leukocyte, or the WBC, has got on its surface a protein called LFA1, which is attracted to the cap of the clown, which is the ICAM1. How does Lifitegrast come in? Lifitegrast is a lymphocyte function associated antigen, which is what LFA1 is, antagonist. So it antagonizes the LFA1, which is sitting on top of the WBC, that blocks the T cell binding to the intercellular adhesion molecule 1, which is ICAM1, which is on the inflamed cell, which is a ligand expressed on the inflamed ocular surface and on the vascular cells as well. So this is just the crux of the matter I want you to understand. So there is normally a love story between the LFA1 on the lymphocyte and the ICAM1, where the white blood cell comes rushing to the inflamed epithelial cell. There's a mistake, that's another 6 minutes. So in chronic dry eye, it requires treatment to target the root causes. So FDA has approved Lifitegrast as the first prescription therapy for this because it blocks the binding between the LFA1 and the ICAM1. So I won't go into the pharmacodynamics, but basically Lifitegrast prevents the T cell activation, reduces therefore cytokine release, which is a much later thing to happen, disrupts the immune synapse and decreases inflammation. The pharmacokinetics are quite good. It strong inhibition of T cell adhesion to ICAM1. It's highly soluble, unlike restasis, gets rapidly absorbed, rapidly cleared, and has a good safety profile. Just look at the upper greens. So, is there evidence? Yes, it reduces fluorescein staining. If you see just the lower part, corneal fluorescein staining score, Lifitegrast versus placebo, especially the inferior corneal staining score is reduced. It reduces lissamine green staining. So we know that the more the staining, the more inflamed the eye. So it reduces lissamine staining as well. It reduces the ocular dryness score. So if you do an OSDI or a DEQ5 or a questionnaire and ask the patients about how they feel better with it as compared to placebo. And it has excellent bioavailability, early onset of action in 14 days in the Opus 3 study, and long-term safety, which was seen in the Sonata study. It also shows a reduction in artificial tears dependency and in need for steroids. So this are some of the published papers on this. Improvement in eye dryness symptoms from the Opus 3 study. Reduces the need for artificial tears in another study, the Sonata trial. And it's not inferior to cyclosporin in a paper published at the IOVS in 2022. When they compared it to cyclosporin, it was not inferior, which is a great thing. It significantly improved patient symptoms and signs compared with treatment for obstruction as well. So it is recommended that it should be used even for inflammatory MGD. We know that almost 75 to 80% of our dry eye patients have some element of MGD along with it. Either it's mixed dry eye or it's MGD dry eye. So Lifitegrast works not only in aqueous deficient, but it also works in MGD. There is the papers published to prove this as well. And the IJO study in August 2024, which is published, multicentric double-blind parallel group study versus CMC. Why versus CMC? Because whenever you do a trial, as far as the drug controller is concerned, you have to do it against an established drug used for the treatment. So you can't do it straight away comparing head-to-head with restasis. You have to do it first with CMC. And when they did it, they found that OSDI score drops and the breakup time tends to improve in these patients. If you do it again after 12 weeks of treatment, the improvement in symptoms and signs in the Lifitegrast group compared well and as compared to the CMC group. So summary and conclusion of the phase 3 trial was that it is well tolerated. It's a well tolerated drug. The Indian trial established it can be considered as an effective alternative option in the therapeutic armamentarium of dry eye disease management. To summarize, dry eye is a huge issue. We know about the other things. We know that it is not inferior to cyclosporin. We know that it acts faster than cyclosporin does, and we know that because of the Sonata trial that the safety is well established. There are side effects, irritation, transient blurring and dysgeusia. I would put it in level 2 of used to patients. That's the dry eye workshop study of 2017. So level 2. So start it early, just like you would use topical cyclosporin. No studies, as far as I know, have been done to see the additive effect. But ever since I've been using it since the last almost a year now, I have usually used it in patients who are already on restasis and don't have the optimal effects. So I add the Lifitegrast because it works at a different action, an earlier action, and I find that it does tend to help. Very few of my patients are those on whom I've discontinued Restasis and put them on Lifitegrast. Thank you so much for your attention.
Thank you, sir, for that excellent talk.